I want to say thank you to Dr. Lindsay, Dr. Jacquard, and to Provost Fleming for the opportunity to be here today. I'm quite honored and humbled to be in this room with so many smart, intelligent, and overachieving individuals. You are the future and the present in the war on poverty, and how we reshape our country, if not the global community, on how we're going to respond to improving access to care, improving the gaps, if you will, and those disparities that we know so well in our underserved and marginalized communities. I also want to say that the Surgeon General sends his greetings to you. We are working very hard to make sure that the work that we do in the Office of the Surgeon General is responsive to the needs of the most underserved populations in this country. And there are a couple of things I want to make sure I discuss today that not only dovetail very well with your theme, translating knowledge into action, but I want to specifically focus on trying to personalize the importance of everyone, regardless of their race, their ethnicity, their social status, or their educational level, the importance of them having access to health care, but also having the opportunity to be healthy. And they're two distinctly different things. So I wanted to put that out there as a precursor before I start my remarks. But I want to focus on today, my talk is specifically focused on health and poverty in underserved populations. And Dr. Lindsay, you and I share a lot of commonalities in our background, in that I grew up in rural Virginia and in a poor farming community. My parents did not go to college. My father did not graduate from high school. My parents and my grandparents were always making sure we understood the importance of education. My mother's famous line for me and my two siblings is that education is the great equalizer. You will do well in school, you will pursue college, or you will pursue a skill that will allow you to be successful in life, and that you do not repeat the same cycle of poverty and disadvantages that many before you have had to face. And I will say that the biggest champion in my life has not only been my mother, but that village that surrounded the community. And it was composed of a number of things. The faith community, the school system, and those who either knew my family or those who were invested in making sure that the children had an opportunity to do better. And that may have been volunteers from the community, nonprofit organizations. And it really is true, that African proverb, that it takes a village. It really does. But we as healthcare professionals, and we as leaders and academics, and also as scholars, we need to recognize our role in having an impact on changing the future, and it starts today. So first and foremost, I want to say that I have no financial disclosures that would potentially lead to a conflict of interest with this presentation.
I just want to fix something.
Okay.
So. No, it wasn't you.
It wasn't me this time?
Nope. Hang on 1 second.
I'm going to be very extraordinary this morning and be patient. I'm not known for that. And most people who work with me can attest to that. We're good to go? You promise? Okay. I'll take your word for it. As I said, I really don't have any financial disclosures to push my mic down. This way? Is that better for everyone? Excellent. I like doing things correctly the first time, but if not, I'll retry. Okay, as I said, I have no financial disclosures that would potentially lead to a conflict of interest. I have a few objectives. Are we on the right slide now? One more. Okay. The first objective is I want to discuss the connection between health and poverty. And there's a very distinct connection, as you all have, I'm sure, heard from our previous speakers. And I want to talk about the barriers to achieve individual and population health, discuss the social determinants of health and the potential impact on our communities, underserved communities specifically, and identify strategies to improve the health of underserved populations, collectively and individually. So health, the World Health Organization had some great ideas back in 1948. And health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease. And this is never more prevalent and applicable than it is today. Why is health so important? Because our health impacts every aspect of one's life. It is our physical, mental, and our social well-being. It affects one's ability to live a fulfilling life. And it has a direct impact on the health of the community, population health. And that's basically how we get to the point of being able to now look at those social determinants at a community level. Before we had the opportunity to look at data from a cross-sectional standpoint and also cumulative data, we did not fully understand the impact of one person or a family in isolation of having data for the entire community. In the HIV world, we call this, when we're looking at viral load, we call it the community viral load. And if you can get the community viral load of HIV down, you have a better chance of reducing the risk of infection. The same is true for poverty, low academic attainment. It is also relevant to mental health. If you can decrease the likelihood of a child being diagnosed with depression by providing them with the tools early in life, you increase the likelihood that that child can live a healthy and fulfilling life. What are the factors associated with health? The first and foremost is poverty. And I realize on some of these I'm preaching to the choir, but I have to go through all these steps so that we can connect the dots at the end. Food and nutrition. How many times have we seen homeless individuals living on the street, no food, and this has become so commonplace, we've almost become desensitized to it. How many you see children in school who are not able to pay attention because they're more concerned about being hungry that they can't even listen to the lesson that's being provided for them. Environmental health is critical, especially at this day and age. And I will tell you, I have some colleagues, fellow officers who work at the Environmental Protection Agency, also famously known as EPA. And we looked at some of the statistics related to the environment, specifically asthma. And I was shocked to look at underserved communities and the impact of asthma in the last 15 years compared to 40 years ago. Part of it is indeed the environmental pollutants, but it also has to do with the health status of our children, because if you're already immunocompromised, the likelihood that you will succumb to other respiratory, cardiovascular, or other hematological conditions is very high, because your body is so worn down by environmental factors that you have no immune response to those things that would not normally impact you. Mental well-being is another factor that impacts one's health. We in this country live in, as we call in the military, the suck it up mentality. Just get over it, move on, keep moving. That doesn't work, people. We have a cycle of trauma that is happening in our society that has never been seen before. The Surgeon General and I have been having some very detailed conversations with our partners at the National Institutes of Health, at the Centers for Disease Control and Prevention, SAMHSA, and the national nonprofit organizations about how do we, as a country, prioritize mental health. But it's not only just mental health, emotional well-being. Emotional well-being is a campaign that we'll be launching here in the next couple of weeks. The concept is this, and I'm a nurse, so I confess I'm a clinician. I have to use clinical examples all the time to make sure people understand me. So I will do that a lot today. So mental well-being is not just having the absence of a clinical diagnosis of anxiety, depression, schizophrenia, or the whole host of the other multitude of mental health conditions. But it is also, are you able to live your life free of stress? Are you able to live your life without feeling that every morning you get up, you're overwhelmed with just the events of life? And this is what we're doing as over the next few months, and that's looking at emotional well-being as it applies to health, looking at emotional well-being as it relates to one's ability to be resilient and to deal with just the factors of life. And what we're seeing as we start to look at some of the research, both from NIH and CDC, is that most of us are not emotionally well. And when I say most, there are data elements that support this. The household survey back in 2 years ago looked at the number of individuals that identified stress as being a major factor in their lives. And there had been a 10-fold increase over the last 20 years of how many people identified that stress was a major factor in their life on a daily basis. This is staggering. We live in a microwave society. We all want information in our hands, literally. And as a mother of a 21-year-old and 15-year-old, I tell you, it drives me crazy for me too when I can't find out where they are when I need to know where they are. So we fed into this addictive mentality also of having so many things going on in our lives that our mental well-being is at risk. Healthcare, access to healthcare. Access to healthcare is such a major factor for individuals who live in poor and underserved communities. I spent the vast majority of my career, if not all of it, working with underserved communities. And one of the biggest factors for us in being able to determine whether an individual would be able to recover, improve, or to be able to be rehabilitated revolved around their access to health care. For poor people, it's not an option because they can't afford to, first of all, if they have a pre-existing condition prior to ACA, they couldn't get insured. And once they got insured, they couldn't afford the premiums. And if they could pay the premiums, they couldn't afford the copays or the deductibles and all those other things that go with health insurance. And so making sure that we have the access that is appropriate for the individual where they live and where they work is critical as we look at decreasing disparities in health and health care. Safe and stable housing. For the homeless population, this is not only relevant, but it is for people who live on the fringe of being almost homeless. There are many people who are one paycheck away or half a paycheck away from being homeless. And they just ride that wave that comes with a lot of stress, anxiety, and other social determinants of health that relate to poverty and lack of available housing. Education, clean air and water supply. In many communities, Flint has been a scourge on this nation. For us as a country not to fully dive into Flint is deplorable. And I accept part of that responsibility because of where I sit in the organization. But I understand that this is one of the biggest policy challenges that we as a country have faced because the multi-level, multifactorial level of failure when it came to Flint is absolutely unexcusable. And I say that in all capacities, especially as a clinician. Strong relationships and connectedness. We find that for emotional well-being, strong relationships and connectedness is important, but it's even more important for someone to have good health. But there are also barriers to health care. And the barriers to health care from an academic and from a policy standpoint are usually in 3 different categories: cost of care, quality of care, and access to care. But it's not just based off of those 3 components. We know that having access will allow us to prevent disease and disability. It allows us to detect and treat illness and other health conditions. And it also helps to increase one's life expectancy and their quality of life. but it's a bit more complicated. Because barriers typically can be broken down into those structural barriers, such as transportation, childcare, geography, and social factors. From a clinical standpoint, as I worked with some of the Ryan White HIV grant programs over the years, we did a number of demonstration projects. One of the most fulfilling programs I ever worked with was this Women of Color initiative, and New York was a big part of that study, because we identified that you don't build it and they will come, because it doesn't work that way. If you build it, they might find out about you, and then they might come, but they may not walk in the door. And if they walk in the door, they may not like what you say to them, or they may not like the decor of your waiting room. And if you have a receptionist who doesn't have a good attitude or is not a morning person, help me somebody, it may not be a good day for that patient. And what we learned about this was that it's not about us. It's about us creating an opportunity. It's creating an environment for patients to be able to articulate to their providers and the system of delivery what's best for them. So here's what we did. When you saw one program in this linkage project, you saw one program in the linkage project. For those that were co-located with all the services under one roof, their missed appointment rates went down, their no-shows went down, their return for lab results went up, and guess what happened to their quality indicators? They skyrocketed. But that's just part of the story. School attendance for their children went up because we provided transportation for mom to get to her appointment. She didn't have to take 5 buses and 3 cabs and everything else in the whole network to get to her appointment. She had childcare on site, and we did joint appointments, so mom, baby, and toddler, and the preschooler could all get care in one location, one-stop shopping. But that didn't work in the rural communities. Like I said, one program, one patient, one set of issues. But what worked in the rural program was that we put the doc in a box and take the patients, leave them where they were, and take the doctors out to the location where they were best needed and best utilized. There's an innovative program in Colorado where we actually flew a provider who had HIV experience, OBGYN, and a nurse practitioner who understood GYN care and the components of transportation, childcare, nutrition, and community engagement for underserved, poor HIV-infected women where they lived. Now, rural communities and stigma, real life situations, right? But when you don't call it what it is and you make it what it needs to be, you see a lot of impact. So what we did is we nicknamed these programs all kinds of creative things. Some of them called their programs the Women's Health Improvement Project. Some of them called it the Family-Centered Care Network. Whatever worked for them to maintain the confidentiality but improve the impact of having health care available for poor, underserved, and socially marginalized individuals, we supported. The system barriers. And this is the one thing that I can say, not my children, but it is the regulatory and statutory barriers. That's where all this gray hair came from. The few strings that are up here, that's where they came from. Because here's what we know, and this is true with ACA, it was true with Ryan White, it was true with the Public Health Service Act in 1930, whatever, is that all well-intended laws and policies have things that just don't make sense to real people who have to implement these programs. So for those of you who are trying to implement programs with federal statutes and all these other policies and regulations, I'll keep praying for you. We knew as clinicians there were many things often across the spectrum of the federal space that prohibited us from doing what we knew was right. And when I say that, I mean, you know you can't fund certain drugs under certain programs because the dollars have to be separate and distinct. But we have an obligation to the public to work with HRSA, where I used to work, to work with CDC, NIH, and SAMHSA, and other partners in the federal government, including CMS, to make sure that we're covering all the gaps. And I want you to hold us accountable for that, because that's the only way that we'll get poor people, poor communities out of that rut. We have to create opportunities for people to engage and feel a part of the process, but as I said, as we did with the Women of Color Initiative, get the input from the community and figure out what are the needs and how do we meet those needs. I'm convinced there's enough money in a lot of these programs to deal with some of these challenges, but we need to figure out how to use the monies more effectively and more efficiently. Population level differences, as Dr. Lindsay spoke this morning, we know that African Americans, Hispanics, and American Indians are on the lowest of the totem pole when it comes to looking at health indicators and socioeconomic indicators. But those socioeconomic factors drive the health indicators. In our poorest communities, we have the lowest educational attainment, and we also have the highest rates of uninsurance. But they're the highest need. And need needs to drive the dollars. It has to drive those gateways, if you will, of how we engage in care. Now, health disparities. This has been an ongoing topic, and how is it that health disparities and healthcare disparities are different? They are different. Because a health disparity refers to the higher burden of disease. Again, clinical example. HIV epidemic, in late 80s, early 90s, gay white men. Those were the epicenters. Your San Franciscos, your New York Cities, your Miamis, your Chicagos. That's where when we focus all of our dollars, for once we got that part right, we put the dollars where the burden of disease was. But as the face of the epidemic has changed, we've not done a good job in shifting resources to the Southeast, where 30% of the cases in the country are women. But if you go to the South, guess what? In some communities, 65% of the new cases of HIV are in African American women under the age of 35. The fastest growing new population of HIV infections, women of color over the age of 55. But don't ask me to tell you how many new programs have been established to address those two populations, because I don't have an answer for you. A healthcare disparity refers to differences between groups in health insurance coverage, access, and the use of care, quality of care. So when you're looking at health disparities, it's that burden of disease. And we have to transition all of that knowledge. And now, how do we make sure that those who have the biggest burden of disease, that they have access to insurance coverage? And that's what our President, Barack Obama, was trying to do with ACA, was to bridge that gap, to make sure that the dollars and the resources could get to those who had the highest needs by using data, having evidence-based models at the community level, responsive to the needs of the community, very specific and catered to those services that were needed by the community, to include not just physical health, a clinical diagnosis, but behavioral health, as well as social services, to make sure that case management, when it needs to be intensive for an elderly person who's living isolated and alone with heart disease and hypertension and other cardiovascular conditions and joint conditions, could have a home visit if needed. But that's not the norm in most communities. Health disparities, a whole range of health disparities. But there are two factors that stick out: race, ethnicity. When you look across the spectrum of the health indicators, you'll see that race and ethnicity drive a lot of the factors associated with access to health and those disparities thereof. We're seeing more and more challenges as we cross the age spectrum. Medicare, the vast majority of people over the age of 65 have access to some form of health care. Whether they can pay for Medicare Part B or not, they have access to some form of health care. The largest gap of individuals who do not have access to health care are those individuals between the ages of 45 and 64. And that is when most people start to have development of chronic diseases. Prevention would be critical in those areas in that time span, because it helps to decrease disability as one ages over the span of their life. Health disparities. There is no one location for health disparities, but they do vary significantly in location. If you're in an urban versus rural community, you tend to see more trauma in rural communities that are not usually cared for in the same way or same rapidity that they are in an urban area, because you don't have a level 1 or a level 3 trauma center in most rural communities. And the likelihood if you have an MVA in rural Montana is death, which is much more so likely than if you were to have an MVA in, say, Washington, D.C. or New York City. The resources, the health resources and health manpower is just not there to meet those needs. So these health disparities exist, but if you are poor and you live in a rural community, the numbers skyrocket. Those are some of the disparities we need to focus on. State to state, Medicaid programs vary so much from one state to another. If you look at the formularies alone for Medicaid in New York City and compare that to Mississippi, you see such huge variances. And we need to make sure that those are factors that play into our planning for healthcare resources, and healthcare planning at the state and regional level need to take into consideration those interstate needs, those regional boundaries, and how health manpower can or cannot be available to individuals just across state lines. I think the Affordable Care Act tried to address some of those things, but not in the level of intensity that we see needed. There is a direct link between living in poverty and low educational attainment and poor health outcomes, increased morbidity and mortality. That's been a fact for many years. But what we see now is that it's exacerbating. As the number of individuals who are unemployed has increased, individuals do not have access to employer-based insurance. The ACA corrected some of those challenges, but we're still continuing to see more individuals who run small businesses unable to afford to cover their employees. So their employers will opt out of allowing individuals to be full-time, and when you're part-time, you're less likely to have health insurance. But how do we get to a point of health equity? Well, we need to address the social determinants of health, such as education, economic stability, stable food sources. We have so many food deserts across the United States, and this is something that we have addressed with many communities. I'm very focused on looking at how kids in communities such as in Chicago and also in Detroit have been involved in innovative programs to have school-based gardens. The schools had documented that they just did not have access to fresh fruits and vegetables. The budgets in the school system didn't allow it. They had cost-prohibitive measures related to just meeting the needs of the school system in general. Couldn't pay the teachers, didn't have money to heat the schools in Detroit. So what do? Well, the community, the nonprofit organizations in the community decided community gardens. If we're able to have community gardens, the schools can then raise their own fresh fruits and vegetables. This has been phenomenally successful, but it took partnerships across these geographic areas to be able to make it happen. But it taught the school children some basic skills about life, taught them where food comes from. What is a fresh fruit and vegetable? Well, how does it grow? And it gives them a skill set that will stay with them for the rest of their lives. Looking also at the health status within communities, their neighborhood, and the physical environment. Many challenges face us right now, and particularly as it relates to the social determinants of health. Because the WHO says that the social determinants of health are mostly responsible for health inequities and the unfair and avoidable differences in health status seen within and between countries. The social determinants of health, as well as race and ethnicity and sexual orientation, age, and disability, all are major factors as it relates to the social determinants of health. That is very true in this country as well. Globally, we see that there are disparities in access to health care, but we're the only developed country that does not have universal health coverage. The only, and we're supposed to be the leader of the free world. It's not free, we know that, but it costs something to society as well. Are we willing to accept these large gaps in health disparities? Or are we going to continue to accept that poverty is driving a lot of factors as it relates to our health care? So what's being done to address the gaps in social determinants of health? We're making every effort to improve population health, but public health is one of the most unfunded, underfunded aspects of healthcare in this country. We have to push to make sure that population health, public health, that every child can have a flu vaccine, that every child in school can get access to basic immunizations. It is unconscionable that in the Children's Health Insurance Program that some of the basic benefits of being a healthy child are not provided for in every single state. We know that the healthcare delivery system lacks the ability to address childhood anxiety, depression, and other mental health conditions. Oral health care. And this is a pet peeve of mine, because I got spanked a couple of times for not brushing my teeth. But oral health care, one of the administrators at HRSA used to say, if you want to know anything about the community's health, look in their mouth. Never a more true statement. Oral health care across every survey in this country, CDC, the Census Bureau, and the Health Resources and Services Administration, oral health is the highest unmet need in most communities, and it is the one health care coverage that is not a part of most health care plans. We have to demand better. But oral health care, as one ages in life, is a key factor to cardiovascular disease, certain types of cancer, and it is linked to many health disparities separate and distinct from oral health care. So looking at the ways in which we are building sustainable systems, we have to make sure that those social determinants of health specific to a population in the healthcare delivery system have some level of healthcare reform. We've seen ACA. We saw the National Prevention Strategy implemented. But we have not done enough in expanding the scope of services to meet the needs of individuals and populations. So I would recommend that we look at whole system delivery reform as it relates to specific factors. We need to look at how services are delivered. In every community, there's a model. Whether we see the model or not, there is a model. And in every community, for every disease, there's typically a model. And we look at healthcare in a very disease-focused manner. And I just joked with someone at NIH a couple of months ago at the National Library of Medicine. We need to change the name to the National Institutes of Health, because you guys don't study health, you guys study disease. And she laughed, but she said, wait a minute, you're right. And we have all these acronyms in the federal space that really are not counterintuitive to what's really happening on the ground. That translates into policy, and it translates into the way in which we operationalize healthcare at the local level. So here's what I want to say. We need patient-centered services, whereby we address the needs of our patients based off of their unique capabilities and their unique needs. Precision medicine is going to take us leap years into healthcare that is very much, we call it designer healthcare, if you will, at the genetic level. Why not use that database of knowledge now as we develop that evidence to better predict what the needs are going to be in a given community? Case management works. It works well, but you have to have the right people doing the case management for the right populations. We know that in most communities, you do not have concordance between provider and patients. We have to do everything we can to train our children throughout the span of their education to make sure that they understand the importance of education, healthcare, and the opportunities for them in healthcare. Because we're recruiting for the public health service at the end of this presentation. So we want the future nurses, doctors, physical therapists, dentists to grow up in a society where they value health, that they see their role in healthcare, and they become the workforce of tomorrow. But that has to start at the community level. And it can start with something as simple as healthcare providers and teachers visiting schools to share knowledge with them with kids about health, and then bridging that gap between healthcare and a healthcare career. Innovative models of healthcare delivery, as I talked about, having the one-stop shop, only one idea. Telemedicine is another one. Telemedicine has proven to be very beneficial in communities whereby we don't have any providers. We have officers who look just like me in this uniform and Lieutenant Commander Santiago who are in Alaska, isolated from the rest of the world. But they take a boat and a plane to these rural villages, and they provide, through their bag and their camera and their iPhones and iPads and laptops, state-of-the-art care to some of the most underserved, most isolated populations in the country, if not the world. And that has had a huge impact on decreasing the prevalence and incidence of diabetes, cardiovascular disease, HIV, and also substance abuse. but it is the use of the technology, the evidence, and the knowledge that we have in this country that will allow us to make an impact. But while out there using all these devices, we have access to their history of their medical records. So using the electronic health records, mining that data to then look at the population, how those population trends are changing, have changed, and sharing that information with those who are living in that community. And use of data for planning and design of care. We collect all this data. How many of you have written grants or been a product, have been a beneficiary of a grant, and there's always a data form, there's always a checklist, or even gone to a provider and had to fill out a patient satisfaction survey? Okay, what happens to all that information? Exactly. If we're going to collect it, let's use it. And I know the Office of Management and Budget on the federal side has really been cracking the whip on us because they want, and specifically as it relates to certain data elements, they want all of us in the federal space, when talking about clinical services, to get our act together. Because if you're asking the same grantee, if you're asking NYU, Montefiore, and St. Joseph's all the same information about the same patients, why are you not giving them one form? CDC, NIH, HRSA, CMS, all of you guys are, each one of you have 2 or 3 different forms for all 3 different grants. If there are common data elements, the data's not changing, supposedly. Being able to use that data for planning purposes, but making it simple enough for people to use it and make it effective. Team-based care, we need to look at scope of practice. There are some healthcare providers who could meet the needs of children in the schools, who could meet the needs of children in the community, but because of scope of practice provisions, are not able to do that because it's considered in some of the states to be outside of their training and expertise, even though their license allows them to do it. And this has a huge impact on the community, but we need to measure the impact through evaluation efforts. Those evaluation efforts need to be very specific, less burdensome, and outcomes driven. And the reason is because the leading causes of death have not changed that much. The #1 cause of death in the United States is heart disease, followed by cancer and chronic lower respiratory disease. And this is according to the CDC as of last year. But they account for the vast majority of disease in this country. Heart disease, cancer, and chronic respiratory conditions do not start in one's adult life. The building blocks happen when they're children. But we must provide children with information and access to services to be able to prevent this chronicity of death and chronic disease later in life. And I wanted to share a couple slides with you because I want to make this real. According to the CDC, the current trends in life expectancy, and this is going over, this is a 10-year trend from 1970 to 2010, and at 10-year increments. We see the gaps in life expectancy for blacks, all races, and especially for whites. The life expectancy is going up, but we still haven't closed that gap. And for the life expectancy of individuals born in certain communities, it's even lower. Poverty, low educational attainment have a huge impact on the resources and services that someone is able to gain over the course of their lives. But we have to do everything we possibly can to close those gaps. And if we look at the U.S. population by race and ethnicity, we see that in years to come, the majority will become more of a minority. If we do not develop systems of care now, health procedures, educational opportunities for children now, we will have a population of individuals who will be, yes, the majority, but they will have poor life expectancies, the highest burden of disease, and the ones least likely to be providing care to those who look like them. So how do we improve access for poor and underserved communities? As I said, we have to, first of all, recognize that in the United States we have a shortage of healthcare providers. We have to increase not only the supply of providers, but having the appropriate mix of providers. When we're producing physicians specifically in this country, primarily they've been specialists. We've developed a pipeline of specialists. And that met the need at the time. But as we shift into a primary care model, wanting to get more people into basic primary care, we need to increase the number of internists and family medicine physicians that we're providing to the general population. But it's also true that we need more nurse practitioners, we need more social workers, and we need people to address mental health as well as the physical health conditions. Community engagement to identify community needs, community-based models of care that are specifically relevant to that community. What's relevant in New York for African Americans and Hispanics has nothing to do with the needs of African American Hispanics in Texas. And we have to accept that as a part of the way we deliver care. Every community, rural and urban, have different needs. They have different resources. They have different expectations. And the provider mix is always going to be different from city to city based off of what's available in that marketplace. Non-traditional models of care, one size doesn't fit all. And as I spoke earlier, developing that model around the Women of Color initiative for the HIV-infected population was critical for us to be able to get ahead of the tide that was growing. If we want to look at what works for the community, we have to be open to home visits. We have to be open to street outreach. The street outreach models that worked really well in the early days of the HIV/AIDS epidemic are things that worked. We may need to do the same for cardiovascular disease and hypertension. We may have to do the same as we see a resurgence of TB and STDs. Community and individual empowerment. Communities need to have control of the forces within their own walls, to have a voice, to be able to speak out on those factors that impact them on a basic level. Community health centers. Community health centers across the United States, and especially as we saw the growth during the Affordable Care Act, became a cornerstone for a lot of services. But they continue to be underfunded. But they are a place where people can get access to services and referrals to other types of interventions. We need to build pipeline programs, recruiting from within the community. The likelihood that someone who grows up in a community that's underserved is given the opportunity to go into a healthcare field or education or social work, they're more likely to come back and serve in that community or a community that is underserved. And I wanted to share with you very briefly a case study. And this was something that I pulled from one of my projects from several years ago. And this is John. John is a 48-year-old black male living in St. Louis, Missouri. He's one of 6 children, of which only 3 are living. He is an example of the complex interplay between poverty and health. Like many of the country's 46.5 million people living at or below the poverty line, he faces chronic health problems. He doesn't get regular health care and lives in an environment that makes him sicker. He's unemployed, has no health insurance, and has health problems that include high blood pressure, substance use, post-traumatic stress disorder, chronic joint pain, depression, and gum disease. After completing high school, John joined the military. He served for 10 years, but faced adjustment challenges when he returned home from a series of wars. Since leaving the military, he's not been able to get a steady job. He's worked at restaurants, cleaning office buildings, warehouse laborer, and construction. He loves music and often sings at a local community center. His computer skills allow him to search for jobs, but he lacks the resources to have regular access to a computer and other equipment necessary for him to land a full-time employment. For the past 2 years, he's been unstably housed, living on the streets for most of the year. He is not in a regular contact with his family, partly due to his history of drugs and alcohol. He has come to know people at clinics, social service agencies, and emergency rooms, and they have become his support system. For years, he's been stuck in a cycle that is played out all over the country. Without a full-time job, he couldn't get health insurance. Without health insurance, he couldn't get regular care or therapy that might make him employable. Without income, he faced shortfalls and stresses that contribute to his health problems. I use John at age 48 versus a child because what I want to share with you is John's backstory. John, as a child, grew up in a poor community. He was one of 6 to a single mother. He was in and out of school. got into a lot of trouble. His mother told him, as he shared with us, either you go into the military, you're going to end up in jail. So he finished high school and went into the military. But he carried with him all the scars of growing up as a poor child without health insurance, without being able to stay engaged with the community as he grew up. And the other chapter to John's story is that John's also the father of 3 children who, guess what, are now living in poverty with limited access to health care, who are also unstably housed. These are the stories we want to decrease in number. These are the kinds of things we work so hard to prevent. So what can be done? We need to work to make sure that education is accessible to all children, high-quality education, that health, food, and water is not unobtainable for anyone, especially for our children, that the provision of skills and training is allowed for everyone who wants it, and that income redistribution is a reality, and that poverty starts to decrease, especially in those who are facing it at such dire numbers. Now, I'd like to close with 2 slides, and they're my take-home messages, and I won't go into a lot of detail on these, but I want you to understand that from a perspective of at the national level, and also having worked in a lot of local communities, education, occupation, income, and assets make up the socioeconomic status. They are major determinants of health. Children are especially vulnerable to the negative health effects of poverty. Birth to age 5 is critical for development in every aspect, physical and emotional and mental. And just a few years of poverty may negatively affect a child's life course, as we saw with John. The U.S. has higher rates of child poverty than many other countries. In 2012, 22% of children in the U.S. were poor. And in 2014, this number slightly decreased, partly due to ACA and other programs, to 21%. That's not, I don't call that much progress. As family income increases, the number of families reporting poor health decreases. Get access to income, you can improve your health. Many health insurance consumers face limited options, high costs, and incomplete coverage, and that prevails even today. Some 32 million Americans will receive health insurance coverage as a part of the ACA if it is fully implemented as originally designed, and that will remain to be seen. And my last slide, take-home message continued. Child poverty rates are highest among Black, Latino, and American Indian children. Across the states, official child poverty rates range from 11% in New Hampshire to a staggering 32% in Mississippi. And with that, I say thank you for the opportunity to be here, and I congratulate you on this outstanding event at McSilver Institute, and I want to thank everyone at the NYU McSilver Institute and at the university for allowing us to be here. From the Office of the Surgeon General, thank you.